All right. So um, I'm really happy Johanna Shapiro is with us. And she was with us a year ago, and that was a lot of fun. And we're going to do um, today as a kind of interview format. And so I'm happy for other people to pose questions. But but I thought we could begin um, by inviting Johanna to tell us about her career and some of the high points, and if she would would choose some of the low points, perhaps. And and I have a whole bunch of questions that I can ask. So uh, let's just see where we go. And put, I thought you could introduce yourself in that way of talking about the path that you've taken through the behavioral sciences and the medical humanities, and that brought you to today.
Right. Well, thank you so much, Louis and Augusta, for giving me this opportunity. I thought about this as kind of a trip down memory lane for me. And I thought about telling these stories about how we had to walk through 2 feet of snow to teach medical humanities back in the day. But probably that's not even funny in Maine. But in any case, this is great for me to just reflect a little bit. And as Louis mentioned, I'm a professor emerita at the University of California, Irvine, Department of Family Medicine. And I actually taught there for about 44 years, so a long time. And as Louis intimated, I started my career as what was then called a behavioral scientist in the Department of Family Medicine. And that, I don't know if any of you have any connections with family medicine, but it's pretty much the equivalent of what is now called a behavioral health specialist. And so my background is as a psychologist. I don't come from a literature or arts background, which will be relevant later in my story. But so I spent maybe the first a little less than half, but a very good hunk of my career, very departmental based, working primarily with residents to, again, it's interesting because my career underwent this huge shift from psychology to health humanities. But for me, I was always doing the same thing, just in a different format or different structure. So, I always conceived of my role as a behavioral scientist and as a psychologist as helping residents focus on the whole person, on the interaction, the communication between doctor and patient, and how that's affected by a lot of psychological and sociological factors, of which at the time there was very little attention in medical school. So jumping ahead about 20 years, I actually underwent some difficult personal health experiences. And for example, one of them was that I had a spontaneous retinal detachment. And since I had no idea what was happening and it was totally painless, I almost lost the sight in one eye. And it was, I had surgery, I had a difficult recovery, and it was very traumatic. And in fact, I remember that I was in the middle of writing a grant, and I'm talking to my surgeon, like, well, I have to get back to finishing this grant. I have deadlines and whatever. He said, well, you should take a pause because you will be very profoundly affected by this event. And I was like, what do you mean? I'm just going to get my eye patched up and go back to work. But in fact, my surgeon was right. I was wrong. it had tremendous emotional and professional reverberations for me, such that I really started to say, well, what am I doing with my life? And how much do I want to finish that grant? I did finish it. It did get funded, but whatever. I moved on from that point. And so I always say that I invented medical humanities, not joke. I mean, it's such an absurd and arrogant statement, but because I was coming from the field of psychology, which at the time was not connected in any way with, medical or health humanities. When I was recovering from this surgery, and during which time I could no longer read for a while. I lost my depth perception, so it was really hard for me to navigate physically in the world. So as my doctor said, it was traumatic. And of course, being a scientist, I turned right away to the research literature and, read and this and that. And it just made me really depressed and really overwhelmed. And finally, a friend of mine said, here, I brought you a poetry book of Emily Dickinson. Now, I had been an English and then cultural studies major as an undergraduate, but I hadn't thought about this stuff for a long time. And I started reading Emily Dickinson, and it was very consoling to me. And that's why I say that I thought I invented medical humanities, because I thought, oh my gosh, the light bulb. I should teach this stuff to medical students and doctors. They should understand this. So it took me a few years actually to discover that, in fact, I had not invented medical humanities, that in fact it was a huge, robust field that had been around for, at the time, about 30 years, with its organizations and its leadership and whatever. But eventually I did catch up. And I did change my career into something that at the time people in my institution had never heard of. And I'll just offer one more anecdote to show what it was like when we had to trudge through the snow, because I decided that I was going to teach this idea, this poetry and health. And I started to talk to some of my colleagues, and I said, I have this idea. I'm going to teach a medicine and literature course. And everybody was, from my perspective, surprisingly enthusiastic. And I'm like, well, do you even get what I'm saying? And as it turned out, most people thought what I was proposing was an EBM literature course, which they felt was a huge gap at our institution, because we had one of our outstanding librarians was kind of teaching EBM and, how to search the literature, how to interpret the literature, but she didn't have a lot of time to do this. So people thought I was volunteering to do an EBM class, and that was not the case. And their enthusiasm, oh, sorry. So evidence-based medicine, so just the research, the mostly, especially at the time, quantitative research literature to medical students, which was a big need. But so that was kind of the starting point. It was one class. And I will say that not only was this concept entirely new to my colleagues, but it was also completely alien to students. No idea. I mean, I wrote it up, I described it, it still didn't compute. So in that first class, I had 3 students, kind of like you guys, I had 3 students, only one of whom ever showed up. Her name was Apache Yang, so I still remember her. But Apache and I had a wonderful time. At least I had a wonderful time. I think she had at least an okay time. And I was really inspired, but that was kind of the start. And from there, I had the good fortune to be able to build a pretty extensive program in medical humanities that had curriculum in all 4 years of medical school that, put on symposia and conferences and special events like theatrical plays and movie nights and art exhibits. And, we started a literary and arts journal, all the things that are now pretty much standard in every medical school in the United States and Canada. But at the time, it was, very different. And I will say that what shifted things at my School of Medicine, which has never been especially progressive, was the action of our dean of the medical school at the time, Ralph Clayman. He pulled together the School of the Arts, School of Humanities, and School of Medicine. We started having these informal dinners together where we talked about our interests, exchanged ideas. That led to exchange of, faculty. It led to a few collaborative projects. And most importantly, it led to a collaboration between these three schools to write a large, I think it was like $1.2 million grant proposal in the UC system to actually fund a center for medical humanities and develop a program. And again, we were lucky enough to get this grant, which was pretty unusual because, again, it was this medical humanities grant that still nobody really knew what medical humanities was. And the only other similar grants that were awarded to my campus were big data, right? Which at the time, this was about 10 years ago, but it was, people were very interested in how, now we had these very powerful computers, how to analyze just enormous data sets that a human couldn't do. And the other part, being in California, was California water issues. How are we not all going to shrivel up and die? How are we going to preserve water? So, but you can see that medical humanities in that context was pretty incongruous. So, and so we had this grant, which was a 3-year grant extended for 2 years, and then resulted, as we said, in a center, an interdisciplinary center. And that really elevated the profile of medical humanities. Simultaneously, I and other people were working on endowing a chair of medical humanities, which was certainly unique for our campus. And in fact, I think even now there are only maybe 5-10 such chairs in schools of medicine. So and we did succeed in that enterprise, which took about probably 12 years to accomplish, from inspiration to accomplishment. And that was a big deal too, because it secured a position in medical humanities for a faculty member. And that is still pretty unique. So I think one other thing I just throw out there in case anybody's interested, but during this time, this, maybe 20 plus years that I worked in the field of health humanities, I did serve as journal section editor for several different journals in medicine. They're all family medicine or family medicine associated journals. And there again, now every medical journal, I think, publishes personal narrative and poetry. But at the time, it was unusual. And I had the opportunity to be an editor for, 3 journals, I guess, sort of making judgments about the poetry. And as I mentioned at the start, I don't have a literary background. And so again, probably kind of presumptuous on my part, but it also, from my perspective, was a way to bring literature and the arts into the kind of uh, databases, if you will, that physicians were were familiar with and turned to when they had questions. And so my thinking was, and wouldn't it be great if you want to know like what high blood pressure medicine to prescribe, but you also saw a poem about high blood pressure when you open that journal. So I think that's a great place to start. Thank you for allowing me this trip down memory lane. And I don't know, Lewis or anybody, I'd just be interested in your thoughts.
Well, I wanted to add that my daughter is a UC Irvine alumni. So,
Ah,
yes, indeed.
yeah, I have 2 grandsons there right now. So I'm a big UCI booster. It's a great place to go to school.
And the beach. I love the beach.
Yeah, that's we are very close to the beach. That is true.
Yes. And I forget the name of the canyon that goes to the beach from the school. Do you remember? I mean, I'm sure you know that canyon.
Well, there's Laguna Canyon.
Right, Laguna Canyon.
Okay, yeah.
Laguna Beach.
Yeah, we actually live in Laguna Beach, so which is a great place to live.
Yeah. My daughter lived in Newport Beach.
Okay, right.
Yeah. So I thought what I thought was interesting, and I want to invite other people to chime in whenever you wish, but I thought it was interesting the article you wrote about I have it somewhere. That sort of relationship between behavioral health people and family medicine people. And it it reminded me of of how it's still a tense relationship, I think.
Mhm.
And when I was a resident, we were required to do some family therapy and to do some psychotherapy. And we could even block a half day of clinic to do that. And that certainly changed. People,
Mhm.
that doesn't happen anymore. And there's it seemed to me that we were more collaborative when we understood how to do counseling as compared to now when we don't. And we just say, oh well, go see the counselor. And I wonder if you could reflect on your experience with the relationship between family medicine and behavioral health over the years, and if in your experience, if the humanities changed that in any way.
Yeah, but that's a great question, and I agree with you that the relationship is still a sometimes tense one, and I think that we can expand this discussion. Again, I mean, what Lewis is asking about is the particular relationship that developed between, in this case, family doctors and psychologists, so PhD people. But it seems to me, having then kind of had this permutation of career, that a lot of the issues that I identified working as a psychologist remain at least as true when you try to get humanities scholars involved in medicine and physicians involved in the humanities and arts. And what I mean by that is this. In fact, I think psychologists have an advantage because, like medicine, psychology is an applied profession, right? So what's called a practice profession. So psychologists, clinical psychologists are trained to, like Lewis is saying, do counseling, do therapy, intervene. And that's what doctors do too. They intervene. And so I think that some of the miscommunications arise because you think, well, we're both doing the same thing. We're both intervening to improve the health of the patient. And what that misses is how different not only the interventions, but the whole conceptual and theoretical framework from which, for example, medicine emerges and psychology emerges, right? Because, you have the medical model that explains, in some ways, physical illness. But in the social sciences, you have other, like more constructivist models, right? So there are these vast differences, but there's this apparent similarity. When you extend the collaboration to scholars in the arts and humanities who are more, and I don't say this in any pejorative way, but they are not necessarily applied researchers or applied scholars. Their work is very abstract and theoretical often. And it becomes very difficult to translate their knowledge into the world of medicine. And when I mentioned this 3-school collaboration that eventually emerged at UCI, it was a very exciting thing. It was something that, honestly, I tried to make happen for a decade, and I didn't have that clout as just some faculty member. It was when the dean stepped up and like, whoa, we need to make this happen. And it was dean to dean. That's how this happened. The dean said, we're going to do this. And then the faculty all kind of fell into line. But, what I noticed and what I recognized was what I described in that article about behavioral science was this kind of initial infatuation. Oh, this is so wonderful. We're talking to artists and literature professors. And then this feeling of disillusionment because people realized that finding common ground was not going to be easily evident, that they might be concerned about the same things like brain tumor, but how an artist approaches that and how a physician, a neurosurgeon approaches it is really different. I think personally that makes for very exciting, very original collaborations. But I don't think they're as easy as we sometimes think. And I think that both parties really have to stretch to sort of rethink a lot of their assumptions about pretty much everything. So I don't know if that, Lewis, answers, or you can comment more.
Well, I was thinking about the difference between relational and transactional medicine. And I think in today's residents are trained in, it seems to me, transactional medicine. And I've had the experience of sitting with them in discussing a patient and saying, well, if you just see them often, they'll get better. And they look at me as if I'm crazy. And and I tell them that they're as powerful a medicine as anything they can find in the pharmacy. And then they really know that I'm crazy. But yeah, I just wondered if you'd had any similar experiences.
Yes, that's yes, yes, and yes, and yes. I think it was the psychoanalyst and psychiatrist and family doctor Michael Ballant, the British guy who said the doctor is a powerful medication, but we just don't know exactly how to prescribe it, but yeah, there and see, I think that this is medicine in my comments are as a non-physician, as an outsider, so apologies for that. Don't want to step on anybody's toes. But my perception is that medicine is not about intangibles, that for physicians who are dealing with life and death all the time, intangibles, uncertainties, ambiguities are really scary, and understandably so. My parents wanted me to be a physician, and other than being terrible in sciences, I think that kind of responsibility for another person's life was more than I could handle psychologically. Even though I did end up doing that a little bit as a psychologist. But in any case, I think that the distinction you're making between transactional and relational is really good, because medicine, not just psychiatry, but much anyway, of medicine is transactional now. I think there's very little time to develop relationships. In fact, I remember when I first started out in family medicine, I was asked to give a lecture to the residents on the 30-minute hour, right? And it was the idea that, you don't have an hour with a patient. You only have 30 minutes, but that's okay. We can make that 30 minutes feel like an hour, right? And then I noticed that as the years went by, it had to be the 20-minute hour, and then the 15-minute hour, and then the 10-minute hour. And finally I said, and this was one of the factors in my kind of not wanting to be that behavioral science person any longer, I said, you can't put 60 minutes into 10 minutes. It just doesn't, humans aren't structured that way. And this is a ridiculous lecture. So I think there are some what I would call intrapsychic factors that are challenging in forming a relationship with a person who is ill or dying. But in my experience, I feel that the majority of people in medicine, the majority of even physicians, not even talking about nurses, who I think are on the whole a lot better relationally, but I think physicians want that. If you talk to kind of more experienced physicians, they always say that their relationships with their patients are some of the most rewarding aspects of their profession. But I think that, medicine is a business, especially in this country. And so it's structured like a business, and it has to do with productivity and efficiency. And I think that those two things are not all that conducive to relationship. I mean, I think you can have relationship within that context, but when those criteria dominate, relationship is always going to come a distant third, and transactional interactions are going to be very well suited to the healthcare model.
Yeah, we've talked about this before. in the class, but so I'll be succinct, but it's really that it's the model that the British used to run the sugarcane plantations in the Caribbean. That's the model we're using. And the idea that any quote provider is interchangeable with any other provider, and that the diagnosis drives the treatment, and that relationship is unimportant, that it doesn't do anything. And I think the medical humanities proclaim the opposite, really. I was thinking of your paper on the feeling physician, and it's it's interesting because I just analyzed some data on me, because I had the opportunity to work in two different settings. One was a community mental health center, and the other one was more of a private practice type setting, but both serving mostly Medicaid. And so I used a couple questionnaires in both, the same ones in both settings. And in the community mental health center, over the course of 2 years, on average, no one got better. And in the private practice setting, statistically significant improvement, around the significant level of less than 0.01. And what differed was the community health center model made a whole lot more money. And so in this paper that I'm presenting at APHA, I'm raising the ethical question: is what matters more, income or efficacy? And I don't know, have you had any experiences that relate to that?
Well, that's the key. And of course, everyone says efficacy matters more. But really, if you look at the way things work, it is money driven, and it is easy to be critical and just say, we should just care about people, we should care about patients. But these are really tricky issues. I'm not an economist. I don't have any sense of how it works. I see the downstream effects in that, and I would say, regrettably, that money buys efficacy. Money gives you access to, the best treatments. It gives you access to the best therapists who aren't accepting Medicaid and, well, I don't know what you have, like Medi-Cal and Medicare any longer. So, not to get too political on anybody here, but this is a capitalist society. And that informs so much across the board. I think it's one of the reasons why the movement for universal health care, which might, that's not a simple solution either, but why it's been stalled for so many years. It's just antithetical to how we as Americans think about products, and we think of medicine as a product rather than a right. So yeah, so I think that conversation is tricky to have, because you almost have to have it with people who are actually willing to make significant structural changes. And I have seen, some kind of nibbling around the edges of that issue. I think there are a lot of voices in healthcare, particularly in public health, but also in medicine as a whole, that say this is ridiculous. We can't be the people that we want to be in the system. or we make it very difficult. I mean, I still believe most physicians would, in your terms, want a relational model, right? But and they could thrive in it if there were the proper rewards. And sorry, I just want to see, Grace, you said I was asked in my health professions advisory committee interviews, is healthcare? Yeah, exactly.
Yeah, I was given a nice minute to answer that one to the interviewers. For reference, I'm trying to apply to medical school, so that's what I was interviewing for this week. So it's just funny that you talk about that, and that was actually the opening question of my interview. So there we go.
That, yeah, and I think the proof of that, I mean, the proof of what we're talking about is that it is in people's minds. People are trying to grapple with, like Lewis, you said, the underlying ethics of what we do every day, right? So it's not as though this is a closed system, but I think we're a long ways from, if we could even all agree that healthcare is a right. All our behavior in this country is that it is a privilege. And how are we going to, and so we can only do that step by step. And I remember once I was hosting a guest who was interested in the medical humanities program, and he'd been talking to students and my colleagues and stuff like that. He says, well, don't you ever get depressed? And I was like, what do you mean? What do you mean? He said, like, you've achieved so little. Like, well, I never thought of it like that. But if you only can think about the ultimate, the end point, right? The ultimate goal, I think you do get discouraged because change is really hard. And there are a lot of forces against change. But I think, all you can do every day is what you can do. And I do think, again, having this very long view, I do feel that in some respects, medicine is more aware. I mean, even if we were to turn for a moment to issues of social justice, I think there are a lot more conversations about structural racism and things like that, that was simply non-existent. So we don't deserve any sort of pat on the back, but I think that there is some movement. Sometimes it's in a good direction. Is that hopeful? Anyway.
Yeah, and some of the people, some physicians have found that balance with concierge medicine. And we have one of those practices here in Bangor. And I have friends in Phoenix and New York City who do concierge medicine. And they tell me that people never want to come as often as they want them to, or stay as long as they want them to. And they're making a marvelous income. And they have one secretary, typically, no billing people. And they enjoy talking. But the downside is you can't see poor people. So, right. Yeah, they don't see people who are, well, they do see some people who have Medicare because the people can pay. And they don't see people who have Medicaid because those people can't pay. And of course, the fees range. I think here it's $2,000 a year, but of course in New York City, it's more like $10,000 a year. But when you think about it, I mean, my health insurance that I get has a $7,000 deductible for our family. So, Am I
Right. And that's what I mean about nibbling around the edges, right? Because, and I remember when the concierge medicine movement kind of, first started to rise. And I remember reading this. I thought it was it was actually not an article. It was a book chapter written by a physician. And she was explaining why she had decided on concierge medicine. It was really honest and thoughtful and all of this. And I remember that one of the things she said is that I'm going to use the bundle of money I get from this concierge practice to devote, 1 day a week to caring for people with no insurance. Now, I don't know whether she ever did that or not, but I think that my impression of concierge medicine is not overall that it went in that direction. I think that there were no systemic incentives to spend a week caring for uninsured people other than, your own sense of morality. And, you have kids and you have mortgages and you have all these concierge patients and whatever. And I think it's easy for that to fall by the wayside. And I think that's the problem in, concierge medicine is set up to make, as you point out, a pile of money. That's, the capitalist motive. And I have been very disappointed because personally, I love the idea of having a doctor that I could actually, would actually take some time and talk with me and, think about me and all those nice things that come presumably with the concierge model. But I just feel like, it's kind of like do good businesses and organizations. It's not that it's nothing, but it really doesn't address the depth of need that exists in order to make healthcare truly equitable, truly just for people in this country. So, yeah, I don't think concierge medicine is going to do it.
But what it does show is how much money we spend on non-clinical activities.
Mm-hmm.
Because if these people can make a bundle of money,
Mm-hmm.
and that means that in the other settings, that there's a whole bundle of money going into, I don't know, vice presidents of whatever.
Mm-hmm.
We at the local chain, there's 3 vice presidents of patient satisfaction, and they have slightly different names, and I have no idea what they do. And yeah. So
well, see, and that's again, you see how easy, how powerful systems are and how vulnerable individuals are. And again, I think that, a la Foucault, right? Power circulates. So everyone has power, everyone has agency. And I'm not saying that we're all helpless, but I think patient satisfaction is a great example of a really good concept that has gone woefully awry, because patient satisfaction, first, nobody thought about patient satisfaction. Then people started to realize, well, if patients are dissatisfied, they don't come back to you, they go to different practices. And that was an important and really, really significant turning, because in a way it was saying patients matter. What you patients think of us doctors, we actually care about that. And to me, that was a really good development. Then, it became institutionalized. So you have all of these, I think, usually pretty ridiculous surveys. You have all of these, reports generated that show that, this doctor's patients are not as satisfied. You have income tied to satisfaction scores. Not somebody, you know, writing a letter that says, you know, I love my doctor and I'll never leave her. But all of these little numbers, and what it does is, I think where the incentive is to not have a relationship with your patient, but to keep your patient happy. So they think they're satisfied. I don't even know that these patients are really satisfied, but when they fill up the little bubbles, you know, that's what they're marking. So I think that it has a very deleterious effect in the sense that, you know, if a patient says, oh, I heard about this drug on TV, can you prescribe it for me? Keep the patient happy. Here's your prescription. But, you know, where's the conversation? Where's the engagement? And of course, that doesn't happen, or at least I hope it rarely happens. But this is the direction in which a patient satisfaction score now pushes things.
Right. And you remind me, I had to take a mandatory hour of training in how to make patients more satisfied. And they gave us all a mirror and taught us how to fake a smile.
So there you go.
Yeah. And I thought, you idiots, anyone can recognize a fake smile. I mean, this is such bullshit. But that's what we did. So, yeah. So maybe moving in another direction, I wanted to come back to uncertainty, because I wanted to disagree with you about uncertainty in medicine, because I think it's 90% uncertain. that most of what we treat, we have no idea what we're treating. And we're just throwing medications at symptoms. And yes, the 10% of things that are life-threatening, we're pretty good at recognizing. But I think in the daily life of a family doctor, and I think this is why so many people burn out, and I'd like your opinion on this. And I also think it's why the humanities are so important. In the daily life of a family doctor, most of it's murky. People come in with vague symptoms that don't fit any pattern, and it's hard to know what to do with them, and they keep coming back, and nothing seems to actually work, and I think this is this is like the bulk of family medicine. And to me, it's because, the anterior cingulate gyrus can't distinguish between emotional pain and physical pain. And a lot of people don't recognize emotions. And you wrote beautifully about that in your paper on emotional physicians, about the way that physicians make derogatory comments about patients to sort of conceal their frustrations. And it's a huge, well, I was going to say it's a huge money waster, but actually it's a huge money maker. That people keep coming back with these vague symptoms that, and I know you know about the wheel of referrals, how the family doctor sends you to the rheumatologist, who sends you to the, physiatrist, who sends you to the orthopedist, who sends you to the neurosurgeon, who sends you to the psychiatrist, tells you to go back to your family doctor. So I guess that's a long way of asking you about your thoughts about how humanities could make us more tolerant of ambiguity and more open to treating or to being present with people in this ambiguity.
Yeah, well, I mean, you said it beautifully, but I'll still elaborate a little bit on that. So first, just to clarify, I'm in total agreement with you, especially since I also am coming out of the primary care background. Medicine is fraught with uncertainty. I was trying to say that I think most human beings are not all that comfortable with uncertainty. Uncertainty is a kind of difficult place to be in because it's very groundless. We don't have a clear path forward. And what I was trying to get across was the idea that in medicine, not having a clear path forward can be scary, because there often is so much at stake. And so there's a lot of what I would call pretending in medicine, that there is certainty when in fact there is not certainty. And I think that referring to the humanities flourish in that space of uncertainty. I think that artists, writers tend to, I don't know in their personal lives, but in their work, they tend to be more open to uncertainty, to multiple possibilities, even, God forbid, to embrace uncertainty for its creative potential. And yes, I mean, Marina, I like that phrase, ease and uncertainty. And another phrase that goes back to, I think it was Delise Ware, a longtime medical humanities leader, who talked about becoming comfortable with uncomfortableness. I think there's a lot of uncomfortableness in medicine. I think it's baked into this pie. So I think that what the humanities can do is helping practitioners develop ease when they don't know or they aren't certain. I mean, and again, Lewis, too, you have to remember, my primary focus for the last 20 plus years has been with medical students, not, experienced physicians. So that's more my frame of reference. And I think that for these young, starting out almost doctors, the idea that no matter how much they study, they're not going to know everything. They're not going to be able to get all the right answers. That, like you say, there's a lot of uncertainty awaiting them in the profession they've chosen. I think that's a hard thing. But again, I feel like we can give them tools to manage uncertainty. To be honest, I mean, I think going back to that idea of pretense, I think if more physicians just said what you did, there's a heck of a lot of uncertainty in this field. And sometimes it's like overwhelming. And I'm not always sure what to do with it. I mean, that's a great starting point because, that's like how most humans feel, when faced with uncertainty about big decisions. And that's okay. That is just proof that doctors are still, somewhat human, right? So, yeah. So, and I think that it is the humanities where we start to see, you look at a painting or you read a poem. Well, there's just not one way of understanding that work, right? I mean, there can be multiple ways, and they're not just free floating. I mean, you present evidence in support of your interpretation, but there are a lot of different interpretations, and they can build on and inform each other. That's why, I mean, to me, like one of the limits of medicine has been the hierarchical nature of training, so that, the attending physician is God, the residents under him, and I'm using him intentionally here, are supports, and the medical students at the bottom are there to observe and listen and drink in wisdom. And again, that's an exaggeration, but in my experience, medical students often have fascinating takes on patients, which more experienced physicians miss, or, they just don't process things in the same way. And so, if we had more horizontal options, possibilities in training. I'm not saying the whole thing should be horizontal. Doctors do know more than medical students in a lot of areas, but it's also true that medical students can contribute a lot, but that defines the situation as somewhat uncertain. Like there are a lot of different ways of understanding it. And I think that for many physicians, that's uncomfortable. They don't want that. They don't want to think there might be different ways of looking at, whatever the patient's problem is.
Yeah, and if you've read anything by this fellow named Abbas, who's at Dalhousie, but he's a psychologist who's been intervening in the emergency room with people with medically unexplained symptoms before they get the $1 million workup. And he's been so successful. The province just keeps throwing money at him, because in their system, obviously, the province loses if people keep coming to the emergency department and getting mega workups, unlike us where we win. And his whole thing is helping people to recognize what they're feeling. He uses the short-term psychotherapy of Davenlos, which didn't really excite me as a resident, but apparently is working incredibly well for him. And it's just a really interesting example of integrating behavioral health into emergency medicine, which is kind of cool.
Yeah, incredible. And Marina, I would love to hear more about your comment about two-eyed seeing and your take on this. Unmute.
Okay, sorry, I was looking for well, we had this great privilege of attending virtually this conference that Lewis had organized. And I mean, for me, that was just, I said, I'm swimming in it because there was so much insight in, I don't know how to sort of, listening to these experts, doctors and psychologists that were also bringing in indigenous knowledge with, Western science, or I don't want to stumble over the words, but it was so amazing because the richness of sort of stepping back and stepping back in with this. I mean, am I saying it correctly? Is that's what two-eyed seeing is in a nutshell? Yeah. And how efficacious, how effective that was, sort of all these stories of, well, this is how we dealt with this, this person's breakdown or this person's trauma and this person's, how incorporating the traditional herbs and even traditional ceremonies. And I mean, it was just like that different kind of hierarchy of just, I don't know. I'm trying. There was so much information that was so rich for me. It's sort of hard to. It was a feast, and so sort of trying to listen to this conversation through that. I'm like, there's a whole piece missing maybe here about what wisdom is and information. I mean, I'm not a doctor, but just that kind of. I don't know. Anybody else have any thoughts about what that? It's just that richness of what's the answer, where answers come from. In a broken system, right? I mean, we're all agreeing that it's a so that's all.
Yeah, I mean, again, I think that what you're highlighting and this whole concept of two-eyed seeing is just make use of all the resources that are available to us. And to me, it's so, it's kind of hard to understand why we don't do that. But again, I think it does have to do with issues of controllability. And Augusta, I just saw your comment about the arts in medicine and how you have patients doing uncontrolled art. I love that idea, to deal with uncontrollable situations. And that's that kind of broad thinking that we need, and Louis, you may remember this as well, but what we now call complementary and alternative medicine, the whole CAM movement. It went through, again, a very predictable cycle, which was first mainstream medicine poo-pooed it and ignored it and denigrated it. Then there was the NIH established the Institute for complementary and alternative medicine, right? Like a great step forward. But the ways that they allowed efficacy, to get back to Lewis's word, the ways that they allowed efficacy to be measured were all very Western, double-blind studies and so forth. And I'm not against double-blind studies in any way, but I'm just saying that at that point, I think we turned our backs on a big part of what the alternative medicines offer, which is much more individualized. I don't know that it can always be quantified into group statistics. And so I think that's where we think we're using two-eyed seeing, but we were still using one-eyed seeing, or maybe one plus-eyed seeing. And this is again getting back to the real integration of humanities and medicine, is that I see a similar pattern that first is like, nothing, there's no connection here. What are you talking about? Then it's kind of like, well, this is nice. If you want to teach an elective class on poetry, we're not going to stop you. But there is not, well, and again, I feel this is changing now, but pretty recently, there is generally not the sense that this is equally valid, equally important. It matters as much. When Lewis was talking about, the doctor as therapy, or the doctor as a medication, that taking your antidepressant is really important, and having a physician who listens to you is equally important. It's not just, oh, well, that would be nice. It matters just as much. And I think that's where, just think about whatever disciplinary backgrounds you are bringing to your life. I mean, disciplines, the way they have been structured historically, is very siloed, right? I mean, you can instantly tell the difference between a psychologist and a literature professor. They just use different language. They have different foundational assumptions. It's all different. And I think we still have not moved sufficiently on that continuum where we're talking about truly integrative, collaborative learning. And to me, that's the goal, especially for these kind of really complex questions, where you need input from multiple sources.
Yeah, and I've read some papers on the use of art to unleash creativity in solving problems. And we seem to be resistant to that also in medicine. I don't know if you had any experience with that.
Well, this maybe touches on an idea of which I've been enamored for many years, and that's and probably because I am trained in a practice profession, but that's the idea of a clinical humanist. To go back to my conversation about the difficulties that physicians and humanities or art scholars have in actually communicating with each other. I think part of it is because one is a very applied profession, and the other is not. And I think not for every, not every person interested in medical humanities needs to think about application, but I think that very rich things emerge when an artist thinks about, how do you apply art in a clinical setting? How do you use art with a patient? And that's where, I know a lot of humanities scholars are very, very skeptical of this because they're afraid, and I think rightly so, that the 800-pound gorilla in the room, which is medicine, will kind of take them over in a way and use them for their own purposes. In other words, if the artist says to the patient, here, draw a picture of your happiest moment, and the patient feels better, the doctor is happy that the patient is said that was good, but there's something in the experience of making art that maybe is not only about better and worse, right? And once you've defined an art intervention, even maybe as an intervention, you've sort of bought into the medical model, which says, people are sick and we make them well. I think, and again, it depends a lot on what we mean by sick and well, which really needs some redefinition. But that having been said, that co-optive function, I still think that we need to bring the arts and humanities to the bedside more than we do, that it's not just abstract conversations, it's really applications. And I think that through that, both sides could learn a lot. Physicians, for example, could learn that sometimes their definitions of healing are too restrictive. And artists could learn, not in an abstract sense, but in a very visceral sense, about suffering and what that means and how it's expressed. So I don't know, but that's where I would go with that I feel there's a strong place for the arts and humanities at the bedside, and that it shouldn't be entirely adjunctive, that it shouldn't be like this nice add-on. Inpatients, they have a lot of time on their hands, so we'll send around somebody to read poetry to them. That might make them happy or whatever, but I don't think that takes full advantage of the potential of these ideas.
Right.
Can I just have you go back a second? Sorry, this is I'm like taking notes as you're saying this. I'm sorry to jump in, Louis. You're saying that you would want an artist to come to the bedside with an art project, or you would want a doctor to be able to utilize?
That's a great question. Yeah, and
you're saying
right. And I think there are advantages to both. First, let's just take the artist at the bedside implementing an art project. I love that idea, and I especially love it if the artist is seen as an independent entity and not only the handmaiden, the extension of the physician, if that makes sense. So I think there's an independent place for the artist at the bedside. Now, the second part of that, I think, is fascinating because I've done a lot of work, mostly actually, I have worked directly with patients and writing, which is more, my comfort zone. But mostly I've worked with physicians and medical students. And so I really I'm intrigued by the idea, which to me is a very democratic idea. I mean, you go to a creative writing program to learn how to write creatively, and that's great. But I think that anybody can write creatively. I think anybody can make a work of art that has value and meaning. And then I'm not saying there are no discriminations, but so I think that if a physician were to spend 10 minutes at a bedside writing a poem with the patient, it would be incredibly illuminating. And in fact, my evidence, I have a colleague, Dr. Tanwin, who's a family physician, who will not write a poem with a patient, but has integrated sharing a poem with a patient if he thinks that that might help illuminate what's going on. He asks patients to draw themselves on his iPad. And it's that, so that I don't see this as, just a one-way street. Like, I don't see it as artists, for example, going into like rounding with physicians so they can see what physicians really do and what they have to contend with. I mean, I think that's incredibly valuable, but I think it should work the other way too, that physicians need to expose themselves, if not immerse themselves, in artistic modalities so they can start to experience for themselves the benefits of art, and then even perhaps extend that, in some form to their patients. And sorry that I know this is a really long answer, but I do have to elaborate on that point, because you all may be well aware that now in medical school, part of the part of the emerging acceptance of the humanities is because, strategically, very good idea, they've been linked to wellness. And you probably, there are just horrific statistics on physician suicide and impairment, and that is an extremely real problem. But again, going back to the medical model, it's imprinted in our administrators' brains: find the problem, fix the problem. So now we have the problem. Too many physicians kill themselves. Great, give them art, and that may improve it. And that is that kind of linear relationship that I think is very diminishing of the arts, and even dangerous. Like, I don't think you can draw a direct line between having physicians sit around and write a poem and reduction in suicide. It may be there, but I don't think that that's all of what happens. And so I'm very ambivalent about humanities and arts in the wellness programs. I think their execution does make people feel better, and I want people to feel better. I think that's a good thing, but I think it can become very narrow, and the outcomes also can become very narrow. So if physicians don't reduce their alcohol intake and drug use, then we're going to get rid of the poetry writing class, because it obviously didn't work.
Right. So we're back to the efficacy model. If it's not a fast result, then it's not a worthwhile activity.
Right.
Yeah.
Well, and again, I think, language is so friable, but I think it means, let's think about, what do we mean by work? There are a lot of ways in which things work. Just like, the saying, not every patient can be cured, but every patient can be healed. So it shows that we can think beyond something like being cured as the endpoint, and expand that to something like being healed, even if you still have cancer, you're still going to die, or whatever it is. So, yeah. So I think if we had a very big umbrella definition of work, then I'd be okay with finding what works.
I just wanted to jump in and just add that there is a field of artists called art and medicine where they do come to the bedside, and
Right.
they are not necessarily from the arm of the doctor. They are actually usually their own programming. And I applaud the wellness program issue, because that is how much of this gets funded. The arts and medicine, and it's more complicated than that. Thank you for saying that.
Yeah, well, I agree with you, and yes, I mean, I'm not very familiar, but I mean, I'm at least familiar. The arts and healthcare, I mean, they have incredible journals, and when I've occasionally had the opportunity to dive into them, I mean, the research that they do is extraordinary, and I agree with you. I don't think that is a physician-driven movement in any sense. I think that when physicians think about art at the bedside, it often does become kind of, physician-driven in the sense that they have certain things they want to see happen. But I think the whole arts and medicine is obviously much broader. Actually has an amazing a scholarly foundation and an amazing theoretical foundation, of which I would point out probably most physicians are completely ignorant. So yeah, right. It's like it's a great thing, and it could be I think the concept of it now outside of arts and medicine is pretty superficial, and if physicians appreciated the depth more, they would benefit, and so would their patients. So yeah, and in terms of funding, look, that's why I said I'm ambivalent, because and I'm very much in favor of wellness. I mean, I think people should be well, and I think that the arts can heal. So I wasn't saying that. I was just raising uncertainty about these kind of neat, tidy relationships that administrators often make, because just as they give funding, so funding can be taketh away, right?
Right. I think someone said to me the other day when I was talking about the work, "Oh, you mean you're going to come in and do a yoga class? Because that's not going to fix anything." And it's sort of like, I think Stosh, we talk a lot about, he has a project that's based in gardening, and when you have a garden, you have to stick with it. You have to keep showing up. And
That's really nice.
these the wellness, like, let's just plug the hole.
Well, that is my objection right there in a nutshell. That if you are making people well only to send them back into this very, like Marina, you said, this very dysfunctional, broken system, then I think and it's still better to be well or well-ish in the system than broken in the system. But then I think we have to ask some serious questions about collusion. And are we being used by this, really harsh system, harsh for patients and also harsh for physicians? Is it like patch them up and then put them back in? And so I think that, there are more and more people talking about, in fact, I think most of the really exciting work in wellness today is being done on a systemic level, not so much on the individual level, although the individuals matter and they are important. But I think there's widespread recognition that the best way to promote wellness is to make humane systems in which people will flourish, rather than always having to, push against what exists. Yeah. So I think you and I are on the same page, Augusta.
Well, friends, it's time for our 10-minute break. as you know, the 10-minute break comes from the old days when it took a minute to walk outside, 8 minutes to smoke a cigarette, and 1 minute to walk back inside. So I hope that none of you will be smoking a cigarette during the next 10 minutes. And I want to introduce Brian, who's at the bottom of my screen, who's the medical student who's working with us this month at Wabanaki and is doing incredible work with some of our very difficult people. So welcome to the class, Brian.
Nice to meet you, everybody.
So yeah, any words before we take 10? All right, take 10. We'll be back at 17:01. So see you then.
So Louis, I assume this means I can take a break too?